try to speak slowly. In Ireland, we have a habit of speaking really, really quickly. So fast that many Irish people can't understand each other. Just want to say a big thank you to Cochrane Indonesia, and in particular to Deti and Dia for inviting me to speak with you here this morning, particularly in the use of the CTG. So my involvement from that stems from both my clinical practice, but also I'm involved in the Cochrane systematic reviews that address many aspects of fetal monitoring. The presentation I'm going to give you this morning, there are slides available, and through some means we will get a copy of the slides emailed to you, I think. Is that correct? Yeah? There's a lot of slides, so don't try to take down everything that's in the slides. It will be made available to you. If you have any questions as I go along, please feel free to put up your hand and interrupt me. Don't mind discussing things as we go through. And if I'm speaking too fast, please tell me that. Okay. Okay, so what I want to talk about is particularly the systematic approach to the interpretation of the CTG tracing. But just before I go into that, just some of the evidence base. I'm largely using the evidence base that we use in Europe, which is the NICE guidelines, which I understand are very similar to the guidelines that you use here nationally. So the methods available for intrapartum assessment of fetal well-being are intermittent auscultation and continuous electronic fetal monitoring. In terms of intermittent auscultation, so these are the current NICE guidelines and what they say. So they say do not offer CTG to women at low risk of complications in established labour. Instead, offer intermittent auscultation of the fetal heart rate to women at low risk of complications during labour. So some of the work we've done with the Cochrane collaboration, we have found that if you perform continuous CTG on low risk women during labour, you increase their likelihood of having a cesarean section. Well, you double the risk. It's about 130% relative increase in the likelihood of cesarean section associated with the use of CTG compared with intermittent auscultation for women during labour. You increase operative vaginal births, so forceps and von Tu's births, by about 30%. And there is no high quality evidence associating the use of CTG in low risk mothers with a decrease in perinatal mortality. So no high quality evidence that the use of CTGs in low risk mothers reduces perinatal mortality. Indeed, and this might sound a little bit controversial, if you look at the same Cochrane systematic review that has informed guidelines from NICE, RCOG, the American College of Obstetricians and Gynecologists guidelines, etc., this same Cochrane review hasn't found a reduction in perinatal mortality with the use of CTG for high-risk women, which is often counterintuitive. We often think that the CTG reduces mortality or helps prevent mortality in women who are high risk. But unfortunately, we don't have high-quality evidence to support that. It's an assumption without high-quality evidence to underpin it. And that can be quite uncomfortable for people to hear. But that is one of the challenges we have. In a centre I work with in Ireland at the moment, what we're trying to do is develop different techniques for assessment of fetal well-being. You all here in the audience know the problems with CTG. Most babies who have an abnormal CTG during labour will be fine. Would you agree with that? But the problem is, it tells you that many babies are compromised, when in actual fact only very, very few are. And that's requiring you to do many more interventions that are unnecessary. Something we're looking at is, so many of us who've been involved in CTG for 20 years now, the only reason the CTG is still here is we don't have anything better to replace it with. But we all know its limitations. While it's still the best available, it doesn't make it the absolute optimal or the best. So something we're looking at the moment is, so you're all familiar with an adult EEG, electroencephalogram. So what we have been able to do is to perform a fetal EEG, not ECG, EEG. So a multi-lead EEG on the fetus during labour, which gives a better, we hope, gives a better picture of cerebral functioning as distinct from this proxy measure of a heart rate, which is suggested to try and to assess how the fetus is. But the important point from today's talk is, if we're using the CTG, we should have a standardized way of systematically interpreting that tracing. So, in labour for women who are low risk, most international guidelines in the world recommend that if you're using intermittent auscultation to its best standard during labour, you should intermittently auscultate, listen in to the fetal heart rate at least every 15 minutes in the first stage of labour, at least every 5 minutes in the second stage of labour, and you listen in for 1 full minute after a contraction. The rate is recorded as a single rate. When I'm teaching students, sometimes I might see the notes, the records might have written down, by intermittent auscultation, fetal heart rate 140 to 145 beats per minute. If you write that down, that means the person didn't listen for 1 minute. Why? If you listen for 1 minute, a full minute, you will have one number, won't you? But people often just guess. Listen in for a few seconds, roughly this. So if I look at a set of records and I see a range written down, X beats to Y beats, that couldn't have been for 1 full minute. So we should be documenting just one number because that reflects the rate for 1 minute. It's also good practice that we listen into the fetal heart rate before and after certain events. So before we do something, like a vaginal examination, so that if there are any changes in the fetal heart rate, they can be attached back to a particular action we did. So you've all seen fetal bradycardias, or prolonged decelerations associated with vaginal examinations. That is of far less concern than an unprovoked deceleration. So if we can write down what we're doing, we can assess what effect it has on the fetal heart. After the administration of any medications or analgesia, and in particular we're talking here about the administration of any opiates or any regional anesthesia in particular, like epidurals, that might have a vasodilation effect and potentially adversely affect maternal blood pressure, which can affect fetal heart rate. If you're transferring care to another care provider, listening into the fetal heart before that happens is good practice. After the woman's arrival to your hospital or centre, after spontaneous rupture of the membranes or amniotomy, so artificial rupture of the membranes, and after vaginal examination. So I've looked at lots of the international guidelines, ACOG, the New Zealand and Australia-New Zealand guidelines, NICE guidelines, etc., and they all have very similar criteria at which point you should offer and recommend women to have a CTG. So they are the following. If there's an abnormal fetal heart rate pattern, and that's usually indicated by a rising baseline on auscultation, or if you hear decelerations. If mother has a tachycardia, so that's a pulse rate over 120 beats per minute, on 2 occasions, separated by 30 minutes. It's good to have the 2 occasions because it avoids you intervening unnecessarily. Maternal pyrexia, and it's defined as a once-off temperature 38 degrees Celsius once, or 37.5 twice, 2 hours apart. 1 hour apart. Suspected infection. Unusual pain reported by the mother. You all know what the normal pain pattern of uterine contractions is. So any abnormal reported pain, particularly in between contractions, as you know, is of concern. The presence of significant meconium. Now, this caused concern up until 2017, up until last year. There was no definition given clearly in lots of the guidelines. Now, last year, NICE gave a definition of what they meant by significant meconium. And to condense the definition down, it effectively means any meconium that has got particulate matter in it. So it's green stained amniotic fluid, but that's got particles of meconium still in it. So some people call that fresh meconium, some people call that thick meconium, it doesn't matter. If there is particles of meconium still undissolved in the amniotic fluid, it's regarded as significant. Any fresh bleeding that develops during labour. And then lots of the guidelines, and in particular NICE guidelines and the RCOG, have two definitions for hypertension, one severe and one not severe. So severe hypertension is a systolic blood pressure of 160 millimeters of mercury or more, or a diastolic of 110 millimeters of mercury. It's an easy one to remember because it's the exact same levels as the normal baseline fetal heart rate, isn't it? 110 to 160 is a normal baseline fetal heart rate. So the severe hypertension levels are the same, greater than 160 or systolic, or greater than 110 diastolic. Hypertension then, which is less severe, a systolic blood pressure of 140 millimeters of mercury or more, or a diastolic over 90. That has to be shown twice, separated by at least 30 minutes. Okay, that would be regarded as moderate or mild hypertension. And the last criteria then is, if you have one reading of moderate or mild, this one here, plus proteinuria of 2 pluses. That in itself gives cause for concern, particularly around preeclampsia, or gestational proteinuric hypertension, which would warrant a closer assessment of the fetal well-being, which would warrant a CTG. So these are the criteria. What's nice about the 2017 NICE guidance is, instead of just saying something like hypertensive disorders of pregnancy, you should use CTG. Well, different guidelines use different classification systems for hypertensive disorders, as you know, so at least they've given some parameters as to what they regard as best practice in using the CTG. Other criteria at which point you should consider using the CTG and not intermittent auscultation are confirmed delay in the first or second stage of labour. Depending on what guidelines you use, that delay is defined differently, isn't it? So if you look at the American College of Obstetricians and Gynecologists, they have released a statement in 2015 which allows a much longer period of time for progression in labour, in primogravid labour. Yeah. So in that statement about promoting normal birth, they allow, in some cases, over 3 hours second stage, and in some cases up to 6 hours second stage, depending on the definitions that are used. In the NICE criteria, define delay in the first stage of labour as a cervical dilatation of less than 2 centimetres in 2 hours. And interestingly, they define that delay the same for primimparous women as multiparous women. They don't make the differentiation which many of you would have been trained with. I certainly was trained with, you have the rate for multiparous women, so we would expect multiparous women to progress faster. In the NICE guidelines released last year, they don't make a differentiation between first-time mothers and second or subsequent labours. All women, 2 centimetres every 2 hours. After that period, it's diagnosis of delay in labour. If you have excessive contractions in labour, excessive uterine activity, there's 2 forms of excessive uterine activity, as you know. The first one is excessive frequency of contractions, too many contractions. That's tachysystole. And the second one is you can have a reasonable number of contractions, but resting tone in between the contractions not achieved. So that would be hypertonic uterus. What is the normal intrauterine pressure of the pregnant uterus at rest in millimeters of mercury? Someone said it? Normal pressure inside in the mother's uterus when she's pregnant, when it's not contracting. What's the pressure? Less than 5? Bit higher? Bit higher? It's close. It's about 12. It's about 12 millimeters of mercury at rest. There's some given pressure there already. And that's why we often set, depending on the country you're in, we set the TOCO part to either 10 or 20, depending on the country you're in, because it's somewhere reflective of normal intrauterine pressure at rest. Okay? And remember, the CTG machine can't tell you there's resting tone there. The only thing that can tell you if you've got uterine resting tone is your hand. Yeah? You tell the machine what resting tone is. Yeah? If you use oxytocin, any mother where oxytocin is being used to augment or accelerate labor, the mother should have continuous CTG going. This is an important point, and I'm sure this is done in practice, that if you have any abnormality in the fetal heart rate or any suspected abnormality of the fetal heart rate, we should be checking the maternal pulse immediately to differentiate between the maternal pulse and fetal heart rate. The NICE guidelines in terms of documentation, again, quite helpful. So they say the standard of practice, certainly across Europe and lots of the states, would be using this criteria. For women who are low risk, we'll be documenting the fetal heart rate every 15 minutes in the first stage, every 5 minutes in the second stage. Maternal pulse at least every hour. Blood pressure and temperature at least every 4 hours. The frequency of emptying the bladder, so of micturition. Contractions every 30 minutes. We recommend avoiding, in Europe, it's very common to see obstetricians and midwives write down fetal heart heard regular, 146 beats a minute. Do you use the term regular? Yeah. But we don't want a regular fetal heart rate. Do you? You don't want a fetal heart rate that is like that. You want a fetal heart rate that is irregular. Yeah? You want the baseline variability. Yeah? So you don't, regular fetal heart rate is not something you want. So avoid using the term regular. It's very common in Europe to use that term. If you do hear an abnormality on intermittent auscultation using the Pennard or a handheld Doppler, you should document what that abnormality is that's warranting you to move on to CTG. Some of the equipment that's used, most countries that I'm aware of, when they're using a CTG, use external transducers. So they use a belt to monitor the contractions with the TOCO transducer, mechanical switch on the fundus of the uterus, and an ultrasound transducer to monitor the fetal heart. That be similar in Indonesia? Yeah. We also use fetal scalp electrodes, putting on the top of the baby's head. So we sometimes use a fetal scalp electrode, which is a little clip that goes on the top of the baby's head that monitors the fetal heart rate electrically. It's not an ECG, it's just monitoring the fetal heart rate. That's internal monitoring. Vaginal examination, clip onto the top of the baby's head. There is also a device that's being used in some hospitals to monitor uterine contractions internally. So it's like a little catheter that goes in through the cervix. It's intracervical with electrical leads coming out of it that connects to the machine. It'll monitor the contractions very, very clearly, regardless of the mother's size or her position during labor. But it's obviously very invasive. But the most common ones by far are the external monitors. This is a tracing from a hospital that I work in. Any comments on this tracing? What do you think of this CTG tracing? What's the first thing that jumps out at you? Yeah, someone said it here. No tachograph, is there? No contractions. So we would regard this, so if I was asked for my opinion on this tracing, I would say this is not a CTG tracing. This is a heart rate tracing. There's no T for TOCO, okay? So if you have a CTG, we must be monitoring the fetal heart rate and the contractions. And the contractions must be monitored either by the machine or by your hand, preferably by the machine. And again, I make the point, your hand is needed. The abdominal examination using your hands is really important because it's that which tells the machine when you have resting tone, the position of the baby, descent, etc., rotation. I'll come back to that in a second. I'll come back to that other slide in a moment. The things that we recommend recording on any CTG, the mother's identification details. Who does this tracing belong to? I'm sure you've all worked in hospitals where there's CTG tracing's been done. And I have worked in hospitals, where we've got maybe, not huge numbers of births, but maybe 4,000 births, and we may have one CTG machine. But I've also worked in hospitals where we've got 12,000 births, and we have dozens of CTG machines. I'm not sure which is better. The date and time needs to be correct, and the paper speed, and I understand from Dia, you run the paper at 1 centimeter per minute. Yeah? So this is a CTG tracing of a woman I was looking after. And you can see something happens here. This tracing, the baseline variability is much worse here, isn't it? It's not as good. And the contractions are much more intense. But the only difference in this mother's labor is this. I changed the paper speed. So if I'm looking at a tracing, the very first thing I do, and there's 4 tips I'm going to give you today, 4 tips that I find helpful. If I'm asked to look at a tracing on a labour ward and someone says, Declan, can you look at this tracing, tell me what you think? The very first thing I will look at, the very first thing, is the paper speed running at the right speed. Every country in the world has done caesarean sections at some point because somebody has set the paper speed incorrectly. There's good documented evidence of that having been done. So just check paper speed. It should be 1 centimeter a minute. We should be checking the maternal pulse and using the Pennard or the handheld Doppler to listen to the fetal heart rate before we put on the CTG. Yeah? Why? To make sure we're listening to the fetal heart, isn't that right? So this is a tracing from another woman that I was looking after in a hospital called the Rotunda Hospital in Dublin, which is one of Europe's biggest hospitals. What do you think of this tracing? What's going on here? It's not a trick question. Twins? Yeah, that's the first thing we thought was this twins. It turns out it wasn't twins. This was a fetal heart rate and a maternal tachycardia. And everywhere the fetal heart rate was the maternal heart rate was missing here, it was jumping up to here. The machine was jumping between the two of them. Okay? But the first impression everybody had when this mother came in was this is twins. And that's a reasonable assumption to make. But it wasn't. But this is very easy to detect by checking the maternal pulse. Yeah? So this is another case example I want to go through with you. This is a case from 2007 from an Irish hospital. So just very quickly, just to see if you use similar technology. So this is a CTG that's on a mother who's at 40 weeks and 4 days gestation. This is her 3rd baby, and she's had no problems antenatally, no risk factors. She's come in spontaneous labour, or she thinks she's in spontaneous labour, and this is a tracing that's put on her during labour. There's a few things to note on it. These black marks here, do you see those on your tracings? Yes? And they are fetal movement. Picked up by what? They're fetal movement picked up by the... No, the black dots are picked up by the ultrasound transducer. Okay? These marks here, there, and there, those little marks, are the mother pressing the button. Okay? So the black marks down here are automatically detected fetal movement from the ultrasound transducer, and the mother is given a button to press, and when she feels movements, she's also pressing it. So you have two things checking fetal movements. Okay? So without going into detail here, this is fairly clear. Very good baseline variability. No real decelerations. We can argue about that again in a moment, about the decelerations. But most clinicians wouldn't be very concerned about this tracing. Lots of reassuring features here, particularly the baseline variability. Again here, okay, lots of fetal movements being detected automatically by the ultrasound transducer, and the mother is feeling fetal movements and she's pressing the button. Continues on here. At this point around here, the midwife starts to lose the fetal heart and can't hear it very well. So she summons the obstetrician who comes along, and he's having trouble hearing the fetal heart rate with the ultrasound transducer also. They do a vaginal examination on the mother, and she's about 6 to 7 centimeters dilated with a thick cervix. So perhaps not a lot more than a multiparous type cervix. So they take a decision to take her to theatre to do a cesarean section because of their inability to get the fetal heart rate adequately. Okay? And that's another debate, whether that should have been done or not. They take her into theatre, and this is what this means here, taken into theatre to do the cesarean section. When they take her into theatre, a midwife gets a pennard and listens in, and she can't hear the fetal heart rate with the pennard. So they get a scan in before they do the section, and they look at the fetal heart, and they found the fetus intrauterine fetal death. So the baby's dead. So they didn't do the cesarean section. This mother delivered about 12 hours later, spontaneously. And the baby was born macerated. Macerated? So the baby had to have died a number of days previously. And this is the intrapartum CTG. Okay? Picking up fetal heart rate automatically by ultrasound, and the mother is feeling those movements right up just before the decision is made to take her to theatre. So there's a couple of different things this teaches us. Number one is you cannot tell you have a live baby from a CTG. It is impossible. You can only tell you have a live baby from a CTG if you're also checking the maternal pulse. And I don't have it here with me, but I will send it to Dia. I didn't bring it with me, I just thought of it now. I have a case like this where we're monitoring the baby via the electrical lead, the fetal scalp electrode. So electrical impulse on the baby's head, and the baby is dead. And what's happening is the mother's heart rate electrical impulses are traveling through the dead baby, being picked up via the baby's head, via the scalp electrode onto the CTG. So it's a very simple example that if you have a CTG, check maternal pulse always. This is another example. So does anybody like this CTG? No. So those of you obstetricians and midwives in the audience, you're not very happy about this. This is the importance of not just looking at the CTG in isolation, but looking at the overall clinical picture, what's going on. So this is a mother who had, do you use pethidine? Pethidine opiate? This mother had a normal tracing, and she was given 100 milligrams of pethidine. And this is the tracing 40 minutes after the administration of the pethidine. Now, the real problem here is, can you say this is 100% this is because of the pethidine? Not really, you don't know. Can you say this is 100% this baby is really compromised? No, you don't know. And that's one of the real challenges we have when we're using opiates during labor. Some countries have moved away from opiates during labor for these very reasons. Before I go on, is any questions on any of that? Sorry, please. Yeah.
Regarding the viability during administration of drugs, in here we often encounter the
Might get. Sorry.
excuse me. The recording that you showed earlier piqued my interest because we usually encounter those kind of tracing following administration of magnesium sulfate and dexamethasone. Both of those medication we usually give for preterm labor and preeclampsia patient. So how about the effect, the tracing is because of the administration of the drugs and not by other means of asphyxia?
That's a really good question. So the short answer is we can't. We don't have a means of differentiating what the effects of the medication are conclusively from a potentially compromised baby. And one of the challenges we have, even though we've been using the CTG since 1967 internationally, the first CTG was done in a hospital in 1967 in Germany, we still don't know what the normal baseline fetal heart rate is, for example, for a 32-week infant. There's insufficient evidence to identify what the normal interpretation criteria are for preterm infants. And we probably never will have those criteria. All the criteria we'll be discussing today about baseline rate, baseline variability, accelerations, decelerations, etc., are all based on term infant data. There is some data on preterm infants, but there isn't a consensus as to what the interpretation criteria should be for preterm infants. And one of the reasons that we don't have that, and I don't think we will ever have that, is that a 32-week infant is very different, fetus is very different to a 34-week fetus, is very different to a 36-week fetus, is very different to a 38-week fetus. The physiological changes that are happening in the fetus are so great over such a short period of time that the impact that compromise might have on the baby could be very different on the tracings. So unfortunately, that's one of the big limitations of a CTG. It is very difficult to disentangle the effects of drugs from the effects of hypoxia, unfortunately. The best means we have is identifying, ensuring that you have a tracing that demonstrates this wasn't the position of the baby before administration, and then at least thinking that it may be due to it. However, I think it would be if you give a mother 100 milligrams of pethidine and this is what you get, and you have that running for 40 minutes, I think it would be a brave obstetrician or midwife who wouldn't decide to act on that, even though it's highly likely it was due to the opiates. You can't conclusively say it is due to the opiates. So I think that the administration of medications which we need to do to prevent preterm labor or to increase the prospects for the infant can also give us some difficult decisions to make. When we're interpreting the tracing, so some of the work we've written on, for example, with the CTG is in the Cochrane Reviews and the British Journal of Obstetrics and Gynecology, is this very challenge with the preterm infants, is that we have taken a technology that was developed and criteria developed for term infants, and we're using it much more frequently in preterm infants. And there isn't the same evidence base to underpin its use in preterm infants. So if we look, for example, at the CTG, if you look at the Cochrane review we've done on the use of the antenatal CTG, this is women who are not in labor. So women who have a CTG done who are not in labor are usually high risk. Usually have got risk factors. That's why you're doing the CTG in the first place. And when you look at that Cochrane review, we found no high quality evidence associating the antenatal CTG with a reduction in perinatal mortality. None. Surprisingly, but there is no high quality evidence of the use of antenatal CTGs with reduction in perinatal mortality. And yet it is used antenatally in many countries throughout the world for non-stress tests, for example. So when we come to the CTG trace, the criteria for I hope you can see that although we use this technology a lot, the high quality evidence underpinning its use in some areas, preterm infants, for example, antenatal use, the evidence base just isn't there, despite how much we might want it to be there. When we look at the CTG, what I'd like to just go through is that we have the steps of interpreting the criteria. So there are a number of areas we want to look at. In the systematic interpretation, the baseline rate, baseline variability, accelerations, decelerations, and the fifth one, which is an important one, is your contractions. And all of these then inform your plan of care, what you're going to do, what decisions you're going to take. Interestingly, the NICE guidelines and the RCOG guidelines tend to focus very, very largely on 3 of those 4 features. The 4 features that I'm saying are important are these top 4 here. But the RCOG tend to focus, and NICE tend to focus on the baseline rate, the baseline variability, and decelerations. They do mention accelerations, but it's not included in their classification system. And I'll explain that as we go on. CTG, that the tracing should be systematically interpreted every hour. And in our students, they're given some scenarios and a tracing, and they're required to document their systematic interpretation. So I'd like to go through this, and what I want at the end of the session is that I hope that you find it useful, and that when you look at a tracing, that everybody will use a similar, be able to document a similar findings if you use this criteria. So the baseline fetal heart rate, so this is the average level of the fetal heart, isn't it? It's the mean or the average level, taking over a period without accelerations or decelerations. It's expressed in beats per minute, and the normal range is normal fetal baseline heart rate, 110 to 160. It's the same as the hypertension one earlier on for severe hypertension. So the normal rate is 110 to 160. Now, to make things easy for you, just because it can get a little bit complicated, and I'll give you an idea for a tool that you might consider using in interpreting tracings that is used in a number of countries, in Europe in particular. So 110 to 160 is reassuring. Less than 100 is abnormal. You all agree with that, I'm sure. And more than 180 is abnormal, yes? And anything else is non-reassuring. Okay? So how you write that down then is 100 to 109 is non-reassuring, 161 to 180 is non-reassuring, less than 100 or more than 180 is abnormal. So I say to my students, just know what the normal is, 110 to 160, and just know what abnormal is, less than 100 or more than 180. Anything else is non-reassuring. Is that okay? So on all of the features, what we want to try to do is label them reassuring, non-reassuring, or abnormal. That's the idea. So I'm sorry this is so far away, but for those of you, particularly near the front, if you just have a guess, or just if you can look, what do you think the baseline fetal heart rate is here? On this paper, this is 90, 100, 110, 120, 130, yeah? 120, that's fine. So 120 beats per minute, or 115 to 120 is fine. Yeah. Yeah. We should be trying to keep the range within about 5 beats. So if I was to write down 130 to 140 or 110 to 120, that's a 10 beat range. It's a bit too high. We should be trying to be more precise. So either 120 or 115 to 120 will be fine here. Okay. So 115 to 120, roughly. The baseline variability. Could I just ask, if you were phoning me describing a CTG on the telephone to me, how do you describe baseline variability? More than 5? Less than 5? 5 to 10, 15? So does everybody use a figure, a value to quantify it? You don't use terms like normal, good, flat, reduced, sometimes? No? Just a value. Moderate, minimal, okay? Is everybody happy to, does everybody know how to quantify it numerically? might just take a minute to go through we should be quantifying baseline variability numerically. Less than 5, 5 to 10, 10, 10 to 15, 15, 15 to 20, 20, 20 to 25, whatever exactly it is, we should be quantifying it. And just very briefly, the baseline variability reflects the sympathetic nervous system in the fetal system speeding up heart impulses, and the parasympathetic nervous system slowing down heart impulses. The sympathetic nervous system innervates the heart muscle widely, but the parasympathetic system doesn't innervate the heart muscle widely. It just innervates largely the bundle of His, so the fire, and the atrioventricular node, so the firing centers. So the parasympathetic, if it's stimulated, can have a very immediate and profound effect on the heart rate, which is why you know that when you sometimes see parasympathetic nervous system stimulation in the fetus, the heart rate can drop very quickly. It's also one of the reasons we have a difference in preterm infants. In a preterm infant, the parasympathetic nervous system is much less mature the earlier a baby is, which is why their heart rate is faster. And indeed, those of you who've done pediatrics, for example, even when a baby is born, its heart rate is faster, 1 year, 2 years, 3 years. It's still an immature parasympathetic nervous system relative to an adult, which is why children and fetal heart rates are faster. So if the parasympathetic and the sympathetic nervous system are functioning correctly, they're continuously fighting. Speed up, slow down, speed up, slow down. Which is why you don't want to see a regular heart rate. You want to see this jaggedness, this sawtooth, we call it, edge, like a saw. Jigsaw, yeah. So you want to see it moving all the time. Because if you see that, it reflects good autonomic nervous system functioning. And baseline variability is one of the most important features of CTG interpretation. And you know that clinically. No matter what's going on a tracing, if your baseline variability is good, it's very reassuring. So what we want to do is we want to look at the tracing and we want to quantify what is exactly the baseline variability going on. So what we do is we look at the tracing and we take a 1 minute portion of the tracing, which is 1 centimeter, isn't it, on any tracing. We take a 1 minute portion of the tracing and we see how high up did the heart rate go in that minute, in 1 minute, only 1 minute, and how low down did it go. And we look at the difference between those two values, and that is the value of baseline variability. So if I show you an example, I'll come back to this slide now in a second. So here I've taken a 1 minute portion of the tracing, and I look how high up the tracing, the baseline goes, and I draw an imaginary line. I look how low down it goes, and I draw an imaginary line. And I subtract this value here, which is about 120, 130, 140, 140, 150. This is about 154, and this is down as low as about 140. So the baseline variability is about 14 beats a minute, roughly, about 14. But our eyesight isn't that good. Mine isn't anyway. So if it's 14, that's 10 to 15, isn't it? Put it within a range of 5. If it's 12, that's 10 to 15. If it's 16 or 17, that's 15 to 20, exactly. 22, 20 to 25. 26, 25 to 30. Does this make sense? So you're keeping it within 5 beats because it allows for some minor fluctuations in your eyesight or whatever else it may be. So all these slides will be available via DIA or DETI later on. Okay? So people say to me, well, Declan, which minute do I pick to do it? Because if I picked this minute here, that might give me a very different value to, let's say, this minute over here. Which one do you pick? So an important point to make is you pick a minute that doesn't have accelerations or decelerations. That's the first rule. And the second rule is you pick a minute, not the best minute. You pick the minute that you think this is a very good indication, this is a very good minute to reflect the overall pattern of baseline variability. So don't pick the minutes that are the worst or the best. Pick the minute that's most reflective of the overall pattern of variability. I'll show you a way to check that in a second. So which minute do you think I would pick here? So say stop when I move my green arrow. Which minute would you pick to assess the baseline variability? So you ignore accelerations and decelerations. So say stop. Here? Stop there, yes. Stop there. Stop there, yeah. That might be a bit too much, mightn't it? It might give you a higher answer. But the way to test it, guys, is if you pick a minute and somebody else picks a different minute, if they're both reflective of the overall pattern of variability, they should give you the same answer, shouldn't they? So what I say to people, pick a minute and then pick another minute, and you'll very quickly know whether you're in the right region or not. So on this tracing, the minute that I picked was, and it could be a number of minutes, but this is the minute I picked here. So on this minute, it goes up as high as 130 and down as low as 110. 130 minus 110 is 20. So the baseline variability on this tracing is 20 beats per minute. Is that okay? Yeah. If I picked this minute over here, well, I don't quite have a minute here. Let's pick this minute over here. Goes up as high as 130, down as low as, actually same again, down as low as 110. So it's the same actually. Now, another minute might give you a couple of beats difference, but you should be very close. And that's the way to test yourself. People say, I don't know if I picked the right minute or not. If you're not sure, choose the next minute and see if it gives you a similar answer. If it does, you're good. Is that okay? So that's what you should be doing with all of your tracings. On this tracing, this tracing, which minute would you not choose to assess the baseline variability? You would not do this one because it would give you the wrong answer. It would give you an exaggerated baseline variability. But you could choose basically any other minute, couldn't you? You could choose any of those minutes. So if I choose this minute here, this is 120, 130, 140, down as low as 140, and up as high as something less than 145, the baseline variability is less than 5. Which minute would you choose on this paper, this CTG? Any minute. They're all the same, aren't they? And this tracing is clearly going to give you a baseline variability of less than 5. Okay? Now coming back to the classification system. The classification system 5 to 25 is reassuring. Now, prior to 2017, in NICE and RCOG, the definition of normal or reassuring baseline variability was greater than 5. There was no upper limit. In 2017, they've brought back in the upper limit again. It was there in the past. It went out of guidelines, and now it's back in again. So now it's 5 to 25 beats per minute. Is reassuring. If it's less than 5 beats for 30 to 50 minutes, it's non-reassuring. If it's more than 25 beats per minute, for 15 to 25 minutes, it's non-reassuring. And anything else is abnormal. Now, I don't know about you guys, but when we start looking at all of these classification systems here, I find it starts to get a bit confusing to remember all these things. This to this, less than that. And we haven't even got onto variable decelerations yet. And they are even more complex. So it becomes more difficult. So I do not believe that CTG interpretation should be a memory test of how good you are at remembering all of these different things. So what we've done in some hospitals is we've introduced, you may have them already here, we've introduced really clear stickers within which we put all these criteria. And people just go along and you circle what the tracing is. And it tells you then at the end how you would classify the tracing. So it's allowing the midwives and obstetricians to move away from trying to remember the classification and the criteria for reassuring, non-reassuring, and abnormal, for baseline rate, baseline variability, accelerations, and decelerations. And it's moving clinicians more to looking at the overall picture, the CTG interpretation, and your plan of care. So I'll show you that in a moment. So you should all be happy with how to use baseline variability. I see I've got an amber light, thank you. The next one I want to talk to you about is the accelerations. And a colleague earlier on this morning, gentleman who spoke this morning, he talked about accelerations, and it's the same definition I'm going to use. An acceleration is 15 beats, the fetal heart rate accelerating 15 beats above the baseline, lasting for 15 seconds or more. You all know this. Accelerations are an excellent indicator of fetal well-being. We're doing a trial in a labour ward at the moment in a very large hospital in Dublin, and we're looking at the use of fetal digital scalp stimulation, rubbing the baby's head, and looking at can it replace fetal blood sampling as a means of adjunctive assessment of fetal well-being. That if you get an acceleration, do you need to do a fetal blood sample at all? So the RCOG would recommend that if you get an acceleration, so the RCOG, not quite, they say if you want to do fetal blood sampling and you can't, but you get an acceleration with digital scalp stimulation by rubbing the baby's head, if you get an acceleration, that you may not need to do the fetal blood sample. Our research is trying to see can it replace the fetal blood sampling entirely. So an acceleration is an excellent indicator of fetal well-being, regardless of what's happening with the tracing. So even if the tracing has some abnormalities, if there is accelerations, that's a really reassuring sign. Very, very few babies are hypoxic with accelerations, regardless of what else is going on. So it should be one of the hallmarks of reassurance if there are accelerations present. However, the bottom one is also the case. If you have no accelerations on an abnormal trace, we don't know the significance of that. But in some ways that's okay because we have good evidence on other abnormalities, like, for example, late decelerations and variable decelerations. So the focus, if you have a tracing without accelerations and the tracing is abnormal, your focus should be on those other abnormalities. What happens if you have a normal tracing that doesn't have any accelerations? Are you worried? So if you have a normal tracing, normal baseline rate, no decelerations, and baseline variability is 10 to 15. It's perfect, except it doesn't have accelerations. Would you classify that tracing as reassuring or non-reassuring? Non-reassuring. Interestingly, in the NICE guidelines, up until 2017, that would have been non-reassuring. In the new guidelines, it's classified as reassuring. The absence of accelerations on a normal tracing is of unknown significance, so they classify that as reassuring. Okay. So to summarize about accelerations, if they're there, it's really good. If they're missing, we don't know. So does this tracing have accelerations? Okay. My colleague earlier on this morning, he put up a definition which I agree with entirely. He said the CTG is reactive, didn't he? Yeah. So, and which was really nice to see, he defined what he meant by the word reactive. In the UK and in Ireland, we often see records being written saying CTG reactive. as though it gives an overall assessment of the tracing. Do you use that? So sometimes people write down CTG reactive and write nothing else about the tracing. But the word, as my colleague earlier on said, CTG reactive means the presence of 2 or more accelerations in a 20-minute period. You could have a tracing with late decelerations, and it could still be reactive. Couldn't you? It's possible, and I have examples. So remember, if you use the word CTG reactive, it only refers to the acceleration component of the CTG interpretation. It is not a global assessment of the tracing. Yeah. So this tracing is clearly reactive, isn't it? There are multiple accelerations here. Could I ask you, would you regard this here as 1 or 2 accelerations? 1, good. Acceleration is where the fetal heart rate leaves the baseline to where it returns to the baseline. That's 1 accelerative period. The reason it's important is, if you had no accelerations from here back and no accelerations from here forward, this is not reactive. If you counted this as 2, you'd say it is reactive. Okay? So this is 1 acceleration. Am I okay for time? Okay, thank you. Decelerations. Decelerations, we classify decelerations as every guideline that I'm available internationally classifies decelerations the same now. This used to be the case. But they classify decelerations as earlies, lates, variables, and prolonged decelerations. And I want to go through each of those with you. And I particularly want to go through how you differentiate between the decelerations. Because in my experience in the countries I've been to, and I don't know about Indonesia, but one of the major challenges has been with the variable decelerations and differentiating true early decelerations from variable decelerations. Why are they different? So I'm going to show you a pattern after a while where every single deceleration is with the contraction, but it's variable. Would you expect me to say that? No? You wouldn't have expected me to say that. You'd expect me to say that they differ. That's variable, yeah? Yeah. That's sometimes how people I'm going to prove to you that a tracing I'm going to show you after a while, where every single deceleration is with and associated clearly with the contraction. I'm going to show you why that is a variable deceleration pattern and not an early, even though I've taken it from a case where the obstetrician and midwife have both written it down to be early. And I understand why they did that, but I'm going to show you why it is not early. Before I finish up this morning's sessions, what is the most commonly observed abnormal fetal heart rate pattern during labour? What's the most common fetal abnormality on the CTG, fetal heart rate abnormality you see during labour? It actually is variable decelerations, that's the answer, but many, many people will document them as earlies. But actually, when you go and interrogate them closely, people have written earlies when in actual fact they were variables. And it becomes really important that we differentiate between the two, because early decelerations are not associated with hypoxia, acidosis, or a low Apgar score, and variable decelerations are, maybe. So it's very important we get a clear differentiation between the two of them. But when we go through this session later on, when I show you the tracing that I'm going to say is variable decelerations, if you don't agree with me, I want you to tell me. Is that okay? Don't just say yes. Say, actually, I don't buy it. Okay? And I'm going to stop now for break, I think. And what time we due back at? Thank you all.
Or we have another discussion session after, hopefully after the lunch break we can have more discussion with you.